Hi, my name is Seth Katz, and I'm currently the Vice President of Revenue Cycle and Health Information Management at University Health in Kansas City.
Tell us a little bit about your fiscal year.
Yeah, we're on the same fiscal year as the state of Missouri. So we just wrapped it up in June and started a new one here in July. Always an exciting time trying to close out one year end and kick off a new one and all the excitement that comes with it.
Let's talk about your EHR. True or false? You're on Oracle.
That is true. We are an Oracle Health client.
And how's your progress been?
It's going very well now. I think it's been an interesting couple of years since Oracle purchased Cerner, kind of disrupted the whole industry when that occurred, especially for Cerner clients, longtime clients like ourselves. Bumpy first couple of years as they were kind of lifting up the hood and seeing what they needed to change and update, but we're getting good code quality now. I think people are excited about the future. You're seeing how they're trying to embed AI and improve clinician workflows, and so we're pretty excited about what direction they're going.
So let's talk about your team when it comes to your EHR in regards to getting everybody certified. They're leaning into the system. How's their interaction with Oracle?
It's getting better. I think it takes a village. Both on the Oracle side and on the hospital side. Everyone has to buy in, everyone has to see that vision and where you're trying to get to and understand the problems. And that's one thing we've always really liked about Cerner, and I think that's carried through with Oracle too, is a lot of that customization and uniqueness that you can do with the system. Everyone likes to say their health system is different. We fall in that same bucket as a safety net, and so it works for the hospital down the street, might not work for us. And being able to get that flexibility and understanding of we do have these unique challenges, we do have these unique rules, these different ways we have to calculate different payment rates or whatever because of add-on or dish or things like that. That makes people excited. We can all lean in together on it. We can all see where we're trying to get to, and then figure out what's the best way we can do it together.
Perfect. So 2 questions. So when we talk about your team, how are your teams doing? What's your model?
So we are a centralized team now between the hospital and professional sides on our revenue cycle teams. It's no longer separate and kept in different leaders and organizations. Everyone reports up to one executive, which is nice. We're trying to get better consolidation of teams and centralizing of staff duties. For example, we used to have somebody who does follow-up for a particular payer on both the hospital and professional sides. Can we not build a model where that one person just does follow-up for both sides? We have different systems and challenges there, but there's no reason we need to have that kind of redundancy. I'd rather redeploy staff into new areas that are going to have a bigger bang for our buck. So, we're kind of across the spectrum, centralized up. We got our patient access, we have people who do prior auths and coding and CDI and billing and charge capture. We have our behavioral health teams, the whole group all kind of reporting up and seeing the same vision and going to the same executive.
Nice. So you talked a little bit about being a safety net. Tell us a little bit about your patient population and your demographics there.
Yeah, so we're very proud to be a safety net located in Kansas City. We are about 50% Medicaid by our payer mix, so we're very heavily reliant on that. Luckily, Missouri is an expansion state, so our self-paid numbers have come down some, but they used to be close in the mid-20s before expansion. Our main campus in downtown Kansas City is a trauma center. We're an academic medical center. It's in the urban core, so it has some challenges there with that patient population. We also have a campus that's sort of out in the suburbs that has a more affluent population, so we sort of see the whole spectrum of patients across Kansas City. We see patients from both sides of the state line. We keep our doors open to everyone, and we try to treat them with respect. Very busy place. We've had people come from in the past, Fort Riley come and train in RED and things like that, just to kind of get a feel for how crazy it can be. So there's always something going on. It's a very exciting, very busy place.
Well, with that too, let's talk a little bit about price transparency. True or false? You were one of the first to get it right in your state.
Very true. So we're very proud of. We are a nominal charge provider as a safety net, so we're a low-cost provider. We had no problem when that rule was first published saying, yeah, we will gladly post our charges and our shoppable services. We have no concern about what we charge for them. And we were very happy to be one of the first hospitals around to be compliant, especially in our area. We think it's really important for patients to feel empowered, to understand their healthcare costs, what they might be having to pay when they come for care. We want to be as transparent. Patients are asking for it. It's sort of odd that it's taken an act of Congress to get healthcare to do what literally every other industry already does. And, you don't show up to a restaurant and eat and then get a bill 10 days later and, freak out about why you had no idea why the chicken strips cost so much. So, It's good we're trying to get there, get more patient status, centered. So we're very excited about the price transparency rule and where it's going. And I'll just say for us, we don't mind seeing enforcement, get promoted more. I think it is important for patients and everyone to see that this data is out there, that it's usable. And I'll give a good plug here. It's not just for patients. Hospitals can use it too. We use it in contract negotiations because you can see what everyone around you is getting paid for certain services. So the next time you're doing a negotiation with a payer, you can use that data to help you out.
So we talk about leaning into technology because I think that's what you did in regards to actually being compliant and doing that first. How do you find new technology? And with new technology comes new business partners.
Yeah, I think the three ways we do it, and largely is one through conferences. I still think that's the best way to go with. I don't care if it's local, regional, or national. Walking those vendor halls, meeting new people, just seeing what's out there, keeping abreast of what companies have merged or split apart or what new ones are coming up. To me, that's the best way to find out about what's out there. We also rely then, number two, on things like Class, Health Views, groups that go out there and take real customer feedback. People who took the time to fill out a survey to say, yes, this vendor holds their promise. Yes, they've been successful, etc. And then the third one is we rely on our EHR in Oracle. If we're going to replace our eligibility tool, we're going to go to them and say, who have they contracted with? Who are their other clients happy with? Those are generally the three primary ways that we find new business partners.
Nice. Okay, and to end this, football or baseball?
Definitely football. I'm a Chiefs fan. It's Kansas City. We're winning a lot, so how could you choose anything besides Kansas City Chiefs football?
Okay, cat or dog?
Cat. We have two cats, and my last name's Katz. We're a cat family.
Okay, that does it.